Before we start talking about those sulfonylureas, the insulin stimulators, I'm going to talk some more about things that are common to all the non-insulin anti-diabetic drugs. Make sure you know the nursing implications of taking all these medications. People should have a thorough health history. They need to have their renal and liver function tested because diabetes and diabetic drugs can affect that. And you want to watch out for sulfa allergies, especially with these sulfonylureas that I'm going to be talking about, because if you are allergic to one sulfa drug, it is possible that you can be allergic to another. On Table 17.1 on page 310 talks about your goals for glucose control when you have diabetes. So your fasting blood sugar, that's your first blood sugar that you have when you wake up in the morning, really should be less than 100 milligrams per deciliter. And now they might let that go up a little bit with age. You know, a person in their 70s or 80s, they might let them go under 120 or 125. But the ideal for a young, healthy adult is less than 100 milligrams per deciliter. The most thorough picture of how somebody has been doing with their blood sugar over the last 90 days is something called the hemoglobin A1C test, or HbA1c. And that gives a picture of the average blood glucose over the partial life of a red blood cell. And you've learned that the average red blood cell lasts for about 120 days. So for about 90 days of that, it paints a perfect picture of what that person's average blood sugar has been. And your ideal HbA1c is somewhere between 4 and 6. Now, with every increase of 30 milligrams per deciliter, that's 1% of HbA1c. So a 7 is considered to be 150. So 6% would be 120, 5% would be 90, 4% would be 60. So 4 to 6, or 90 to 120, is considered desirable. Any points above that are going up above 120. So anytime you've got an HbA1c of 6 to 7, they're going to start warning you that your blood glucose is too high and you need to lose weight or watch your carbohydrates. On pages 311 to 312, we've got pretty general info on oral hypoglycemics and other drugs for diabetes. And of course, we need to remember that non-insulin drugs are only going to work for type 2 diabetics whose beta cells are functioning. A type 1 diabetic has beta cells, but they're not working. There is no insulin to work with, so you have to replace it. These oral hypoglycemics are trying to increase the amount that the person naturally already has. All right, so let's move into talking about these specific drugs. So like I said, page 313, we start with the tables. And the first table we see are the insulin stimulators. These lower your blood glucose levels by trying to stimulate the beta cells of your pancreas to make more insulin and to release the insulin that they do store in the cells. Now, the prototype is a drug called glyburide or diabeta. That's been around for a while. Also glipizide. Both of these are discussed on page 313. There are first generation drugs, but our book only lists second generation. They have gotten better as they've gone along, but these drugs have been out for quite a while. Side effects can be a lot of GI irritation, and then adverse effects. This drug could cause the beta cells to fail completely and put the person into type 1 diabetes, where you'd have to have insulin replacement. But usually you're just going to have some GI side effects. And of course, we know biggest adverse effect, hypoglycemia. The drugs that the insulin stimulators interact with are aspirins and NSAIDs, a couple of different kinds of blood pressure drugs, Coumadin, not surprising. Any azole, antifungal drugs, and then a lot of antibiotics. So you just have to be careful when you're taking a lot of medications. These drugs need to be given with meals. If you take it and then you don't eat, you know, you say, okay, well, I'm going to eat in a minute, and you pop your glyburide, and then you get distracted. Something happens and you don't eat. Well, all of a sudden your blood sugar is going to bottom out because you don't have enough food on board. When it comes to these drugs, of course, you're assessing for hypoglycemia. A newer type of insulin stimulator beyond those sulfonylureas is something called a meglitide analog. And there are only a couple of drugs given, and the one we're going to talk about is, as the prototype, is repaglinide, or Prandin. So read about how these work, and they all have the same nursing implications. The insulin stimulators of both sulfonylureas and the meglitinides. There's also a kind called Starlix, but Prandin's the one that you see quite a bit. Patient and family teaching is on page 313. Remember that sulfonylureas can decrease the effects of oral contraceptives, and if you have a sulfa allergy, you got to be careful because you'll probably react to these, and you don't want to use alcohol. If you remember, we talked about disulfiram to help you quit drinking. Disulfiram reactions are true, and there's a sulfa component. There are sulfur molecules in the chemical composition of all these drugs, and so a person who drinks while taking the sulfonylureas might be sorry. They might have a disulfiram reaction.